Okay, good morning, everybody. Welcome to this webinar on Thursday, the 3rd of September. My name is Tian Johnson. This call is brought to you by the Vaccine Advocacy Resource Group, the VARG, and the African Alliance, with the support from the South African Medical Research Council and the Department of Science and Innovation. It's also brought to you in partnership with a range of civil society actors, including the Community Constituency COVID-19 Front, APHA, the Treatment Action Campaign, and a range of other partners. Colleagues, today we're speaking to Professor Sinead Delany Moretlwe, who is the Director of Research at Wits RHI and a research professor in the Faculty of Health Sciences at the University of the Witwatersrand in Johannesburg. She's an experienced clinical trialist with a strong interest in the development of prevention interventions for infectious diseases, including HIV, HPV, and other STIs, and more recently, COVID-19. She's currently the national co-PI for the Crown Coronation platform trial for prevention of symptomatic COVID-19 in healthcare workers. As you would have seen from our social media engagement, there's been a lot of talk about this vaccine that has been used with infants around measles, mumps, and rubella, and we'll be speaking to Professor Delany Moretlwe today to unpack some of her work that she's doing in this space, as well as speak to us in general around COVID, around how COVID research has evolved and changed in her particular context in the last few months. So Professor Delany Moretlwe, thank you again so much for making time and joining us. The structure of this call, as a reminder, colleagues, is that Professor Delany Moretlwe will give us an overview of her work and this particular trial that we'll be speaking about today. And then we will open the floor for discussions. You will be unmuted and you can ask your question, and we'll also share some pre-submitted questions. So having said that, and without any further ado, over to you, Sinead, and thank you again for joining us.
Thanks very much, Tian. Thanks for the opportunity to talk to you and to speak on this platform. I appreciate everyone who's joined because I know load shedding is playing havoc with many of our lives. I think sort of there are a couple of things that I thought would be useful to talk about. I think the first is that one of the most important things I think I've learned during this crisis is the importance of well-designed randomized controlled trials that can quantify the risks and benefits of interventions. And I think that we've had a lot of sort of potential interventions that are being recommended without necessarily evidence. And so as a scientist, I think it's really important that we engage in trials that really will allow us to quantify the risks and benefits. And ultimately, that quantification helps us to decide whether to include interventions in public health policy, but it also helps guide clinicians when they're advising people about potential options. And users know how much of a benefit and how much of a risk is associated with an intervention. So I think that's the starting point. I think the second important point to raise, where there's so much attention that's focused on specific SARS-CoV-2 vaccines, is that, and previously I think sort of other drugs, is that there is a real opportunity to think about repurposing interventions. There's been a lot of work just sort of with this novel pathogen to screen drug libraries, to look for evidence across a range of drugs that might have effects either on the sort of virus itself and the replication pathway or on the host response, and to test these in trials. And the advantage of repurposing is that often these drugs have an existing database, they've been evaluated, they've been used in lots of people, we have the processes to manufacture them, and so some of the barriers around access could be overcome and may mean that we have interventions faster than sort of as we try to develop new drugs or new vaccines. So for us, we became very interested in this idea of live attenuated vaccines that can be trained to use to train the innate immune response. Now, the immune response that we all have consists of two components: the innate response, which is kind of the first line of defense for any pathogen and is fairly non-specific, and the adaptive immune response, which is generally what is used when we have a vaccination. But the idea behind these live attenuated vaccines is that we could prime the immune response such that when it encounters the SARS-CoV-2 infection, our bodies have already basically made cells which are more able to control infection. It feels odd, I think, for some people that one vaccine could work for another infection, but there's some really intriguing observational data that's emerging. I think there's a long, actually, history of live attenuated vaccines being shown to reduce all-cause mortality in excess of just the pathogen that they were presenting. So there is a history of this work. But when it comes to SARS-CoV-2, there's some tantalizing evidence that comes from ecological studies. So in countries where they have better childhood vaccination programs or have implemented measles vaccination aggressively, we've seen lower rates of SARS-CoV-2. Also, kids often get vaccinations and they seem to have less severe disease. There was some data that came from naval recruits on the USS Roosevelt where they had an outbreak, and amongst sort of almost 1,000 people who tested positive, only one was hospitalized for severe disease. So suggesting that maybe there's sort of mitigation of severity. And then very recently on medRxiv, there was an analysis of electronic health records of people who had a history of vaccination, but also had had a SARS-CoV-2 test between February and July of this year. And they looked at a range of vaccines that were given in the last 5 years, but what was striking is that people who had MMR had about a 47% reduction in SARS-CoV-2 infection. So this is not just a kind of a grandiose idea. You know, kind of for us as trialists, we like to see observational data. We like to know that there's sort of biological plausibility, so there is a potential mechanism. And I've talked about this idea of trained immunity. But also, you know, there is the idea that maybe there is some cross protection between antibodies for MMR and antibodies for SARS-CoV-2. But really, if we are to prove this effect, we really do have to do a trial. And so that's why the Crown Coronation trial has decided to evaluate MMR as its first intervention in healthcare workers. And the idea is that participants could be randomized to an MMR or a placebo. It's a very light touch trial, but they would be followed up monthly until sort of 2 months, day 60, and then again at 5 months. And really what we're looking at is rates of symptomatic COVID-19 in the active arm versus the control arm in order to kind of make some judgments about whether MMR works. I think one of the big questions that I'll preempt it is, why would I join an MMR trial if I could join a SARS-CoV-2 trial, vaccine trial? And there are a couple of answers to that. The first is, I don't think everyone may be eligible for some of these trials, and yet many people want to participate. And here we have MMR, which is a safe vaccine. It's been used for a long time. We know a lot about it. There are very few exclusions. And so it offers people the potential to be part of something and potentially provides benefits both for measles, mumps, and rubella. And we are concerned about the potential for outbreaks given the impact of COVID on vaccination programs. The other options are really that we think this is an important idea to test in addition to the specific vaccines, because it could give us a more rapid answer in the sense that once we complete the trial, if we have a result, we may, we already have a lot of safety data. We already have processes to manufacture these vaccines, and we could see fairly rapid scale up in low and middle income countries. This is an intervention that's safe, inexpensive, simple to administer, and the issues of access and scale up could be overcome. That's compared to, I think, SARS-CoV-2 vaccines. There's an incredible amount of work being done. There are phase 3 trials being launched, but we already know that the issues around manufacturing and access are going to be complex, and it would be important to have interventions when we need them now, while we wait for additional interventions. I think the last two intriguing points are that if this non-specific effect works for COVID, it could also work for other pandemics, and people are become much more worried about future pandemics given this experience. But these non-specific effects could then be useful for other pandemics. And the last option is, in fact, that these vaccines could be used in combination. So, for example, we know that the elderly don't mount very strong immune responses, but you could use an MMR vaccine to help amplify the potential response from a specific vaccine. So we think there are a range of good reasons to test this idea. It doesn't compete with other trials. It really is about sort of, rather than foreclosing on a single idea, like I think we did with chloroquine, recognizing that we need a range of interventions and kind of making sure that we can answer these important questions so that we have certainty about what we can offer to people in the kind of near term and the longer term. So I think that's an overview. Maybe the last point to share with you is why healthcare workers, and I don't think that this needs sort of much belaboring, but we know that healthcare workers are highly exposed, either because of their travel to work or the communities in which they live or the work that they do. And that they're really essential, I think, to the social fabric of society. They have been at the front line of this response to COVID, but also at the front line of maintaining many of our health programs, which we know have been severely impacted by COVID. And so making sure that they stay well and that they're not out of the workforce for prolonged periods of time and that we don't lose them as we've lost many people is going to be important. And so that's why we focus particularly on healthcare workers. So I'll leave it at that and happy to take questions, Tian. And thanks once again, everyone, for joining us.
Great, thanks so much, Sinead. So Sinead, a few questions come to mind, and colleagues, please feel free to put questions, comments into the chat box, or if you would like to speak to Prof. Delany Moretlwe, just raise your hand and we'll make that happen. So Sinead, over a decade ago, South Africa had this huge measles outbreak, and it was really attributed to poor vaccine coverage and also highly populated areas. Do you think the urgency and the democratic nature of COVID will change this landscape in terms of possible eventual access and coverage?
Yeah, Tian, so you raised an incredibly important question just about childhood vaccinations. And for people on the call, measles is one of it's an incredibly infectious disease, and really WHO has set elimination targets, and to achieve those elimination targets, we need vaccination coverage in excess of 90% among kids under 1 year, and we're not achieving that quite in South Africa. And there are a variety of reasons for that, and definitely people working on EPI programs are looking at ways to increase that coverage. One of the ways to do that is through these sort of immunization campaigns where kids of any age are vaccinated just in order to achieve coverage. So I do think that sort of increasing information about the benefits of MMR so that it may protect measles, mumps, and rubella, but it may also protect against pandemic infections, sort of we need to define what that period is, would definitely potentially increase the attractiveness. And you and I were talking just before the call about sort of anti-vaccination sentiments. So I do think there's room for work in places like Southern Africa, where we've assumed that there's high acceptability of vaccines, to really understand why we're not achieving coverage rates that we need to, and understand what the concerns of people are. Is it about access? Is it about acceptability? Is it about cost? Is it about anti-vaccine sentiment, so that we can drive uptake of these vaccines and ensure that people are protected?
Thanks for that. So Sinead, a lot of us, especially on this group, have been doing a lot of work, as I'm sure you're aware, around some BCG revaccination trials happening. And one of the key issues that indeed civil society has had was the trial's refusal to procure and provide personal protective equipment to all of their healthcare worker participants. Of course, our point was that a privately funded trial should not put pressure on an already hugely burdened public health sector, where we have well documented, and the Section 27 supported unit that is monitoring stockouts, the stockout projects for PPE have confirmed this. So in a country where we have these national shortages of PPE, ongoing shortages, some resulting in work stoppages and nurse strikes at centres, how does a trial like the one that you will be leading that targets healthcare workers as participants, what is your position in terms of, will your trial procure at your cost and provide personal protective equipment to the healthcare workers that you recruit into the trial?
Yeah, we have watched with huge interest the discussion around the BCG trial, and that was before even sort of work going ahead with the MMR. And at the time, what we discussed, both with the partners that we're working with and with the National Department of Health and with the Clinician Society, which were also running a stockouts, the HIV Clinician Society that were also running a sort of stockouts hotline, is that for us, adequate PPE in accordance with sort of the national infection prevention and control guidelines is kind of a standard of care. And we would expect that in all the facilities that we work, that it's available. And so when engaging with facilities to recruit healthcare workers, part of what our team of investigators are very attentive to is, are there concerns about stockouts? Is there adequate supply of PPE? Are there concerns? And that we try to work with partners to solve those problems before going into an area. Because I think all investigators have a responsibility to make sure that we collectively contribute to ensuring that there is a standard of care. Ultimately, it is the obligation of the Department of Health to protect its workers in accordance with occupational health and safety. But we're in a position where we can identify gaps, stockouts, and then bring people together. So our plan has really been to assess facilities ahead of time, engage with providers there, identify any challenges, work with the provincial PPE coordinators, and work with the stockouts helplines to flag urgent issues so that we can solve these problems. And this has seemed acceptable to all the stakeholders that have been involved in this discussion so far.
Great, thanks for that. I mean, I think certainly the follow-up question could potentially be around what resources really, because I guess in many instances it just comes down to the dollars. And will this particular trial perhaps have some form of buffer in the event that facilities cannot? Or is the principle, if a facility has a history and current environment of shortages and stockouts, the trial might not go ahead at those facilities? Is that the approach of the trial?
Yeah, I think, these trials are not necessarily able to fill a huge void. What we've said is that we can look at what contingencies might be available by working with the network of partners. We've sort of spoken to people at the Solidarity Fund and other partners. In the end, we've wanted to understand what the problems are and work to strengthen the Department of Health so they can fundamentally support these sites to kind of resolve their supply chain issues so that providers are protected. And in prevention trials particularly, because it's about prevention, it's not about treatment, kind of the first sort of approach should be to ensure that you have a robust standard of care and that you're able to deliver that before you start testing new interventions which are layered on top.
Great, thanks for that. A question from social media is asking, if this vaccine was developed for childhood illnesses, could you explain a bit more? Would it be adapted for use in adults, or is this a similar approach to like the BCG revaccination concept where you just revaccinate? And then a tied on question to that would be, what would the situation be with healthcare workers who are enrolled? Would the trial enroll healthcare workers who have been vaccinated with MMR as children?
Yeah, great questions. Essentially, it's a bit like BCG, where we would offer healthcare workers vaccination irrespective of their prior vaccine status. We are aware that there can be some primary vaccine failures, so maybe they were vaccinated at another time point, but kind of we've never assessed whether or not they were protected. What we will do is draw samples at baseline to understand what the prevalence of antibodies to the vaccine is at the time of vaccination. But in the end, we believe that the sort of science is that we're priming the innate immune system to recognize an infection, mount a response, which essentially would lead to reprogramming of cells that will generate new cells that would be better able to respond to infections when they encounter them in future, like SARS-CoV-2. So there seems to be an important idea about recency of vaccination. And while there may be antibodies from prior vaccination, this is kind of just boosting sort of a response. So in short, it doesn't matter if you've been vaccinated before. We will measure, but we will offer people vaccination irrespective of their vaccination history.
Great, thanks for that. You've described this trial as a light touch trial. Could you tell us what that means?
Light touch is, I feel like it's a term that we coined, but it's essentially describes the idea that we have as much as possible tried to adopt principles of social distancing within the trial. So in the traditional way of doing trials, people would come to study sites, they would sit in queues, they would be in waiting rooms, they would see healthcare providers. With these types of trials where we're using repurposed interventions, we can actually do a lot of the interaction with participants over the phone or through the internet. And so we will have a process to screen and consent people via mobile technology. We'll meet them in person to deliver the vaccination, but then we'll follow them up over the phone. We will give them kits so that they can collect samples themselves if they become symptomatic. We will follow them up when they potentially have to go to hospital, but there will be limited in-person physical contact, although we'll have regular contact with them over the phone.
Great, thanks for that. Sinead, could you remind us quickly so the trial is enrolling healthcare workers. Is this all healthcare workers? Is there a specific criteria within that healthcare worker group that you would be enrolling?
Yeah, again, that's a question that's come up a fair bit during the process of development, and I think it's an important question. The way that we've responded to it is that we're interested in all healthcare workers that play a role in the healthcare system and that are potentially through their work exposed to SARS-CoV-2. So we appreciate that those rates of exposure are changing as our as we go through the downturn of case rates, but we know the infection has not gone away. We don't know whether there will be subsequent waves. So it's really working with healthcare workers who, because of their contact with patients who might be infected, they might be exposed, and that's the population we would recruit, which means that it's not just nurses and doctors, but other essential workers who are involved in making the health system work.
Thanks. Age, sex, HIV status, any bearing on your selection of participants?
The age criterion is very straightforward, 18 years or above, so able to give independent consent. No gender requirements, and we do invite people who are living with HIV. The only restriction is that people need to be aware of their HIV status, ideally on antiretroviral therapy, and with CD4 counts that are above 200, because of the concern of giving live attenuated vaccines to people who are not well.
Great, thank you. We've got a question in the chat from Kathy Slack who says, in my view, that the approach to standard of prevention sounds consistent with ethics recommendations and approaches in HIV vaccine trials. Ethics guidelines do not necessarily mandate who should provide prevention modalities, and where study teams will rely on government providers, that they assess gaps and try to strengthen gaps in advance and monitor the issue over time during trials. So what do you think, Sinead, are the ethical complexities that will face the Crown study?
Thanks, Kathy, for that question. I think I mean, having watched what happened with the BCG trial, I think we've learned something, and importantly, we've learned that it's important to engage stakeholders and have a plan and identify how to essentially provide the standard of prevention, which is often, it may end up being a hybrid model, but essentially trying to leverage the fact that as investigators, we have the opportunity to identify gaps and work with other role players to strengthen the system, such that the system can begin to provide. So, I mean, in terms of what could I foresee, well, we could end up with situations where we have stockouts of PPE in some facilities, and we're going to have to work with those facilities to address that. I think if before kind of recruiting, we would, as I mentioned, we would sort of try to fix the system. If things happen during sort of the process of the trial, we're going to have to work with partners to try to sort of address that and think about sort of what that means in terms of recruiting during, you know, kind of during these periods. Which is why we've sort of, it's been incredibly important to also engage with the Department of Health to understand their system, to understand where the problems have been, and to understand who are the providers of PPE so that if we need to call on them for help, we can. So I see the role of researchers as really trying to make the system work. It might not mean that we can put everything in to fix the system, but really to make that work. In terms of your other question, just about ethical complexities, I think sort of the other things that come up in discussions about ethics are really sort of informed consent. We're going to be using a novel approach, which is electronic informed consent. We're going to be doing discussions over the phone. We've gone to a lot of trouble to kind of make sure that the consent process is still adequate, that people are not sort of rushing into things. So there are definitely going to be things we learn as we go along. And as much as possible, I think it's important just to be thoughtful, to try to anticipate all the challenges, but also to build a broad partnership that can help solve them. Because I think in the end, collectively, we're all invested in trying to find interventions that work. And we do need the support of a broad range of stakeholders. But as researchers, I would just like to reiterate that we're acutely sensitive to the environment that we're working in. And, you know, kind of the answer is not everything. It's really our obligation to ensure the safety of participants. And that's always at the forefront of our minds.
Great, thanks for that, Sinead. Sinead, could you help us understand a bit better? And I guess this doesn't only apply to the Crown trial, it would apply across the board, to some of the ethical issues around the use of a placebo. So a question might be, well, why aren't you putting everyone on MMR if we already know it's safe and we're already giving it to children? What is the ethical issues that you can share with us around the use of a placebo, both in this trial and in generally?
Yeah, brilliant question. And it reminds me that I should talk to you about the platform nature of this trial. So the value of a placebo is in order that we have a comparison against which to evaluate the new intervention. And this is because we have equipoise. It means we have evidence to suggest there may be benefit, but there's also uncertainty. We don't know whether this is going to prevent SARS-CoV-2. So it's justified in this instance to offer people a control because we don't have a guarantee of benefit of the MMR, although we think there's high probability. Now, one of the novel features of this trial is that it's an adaptive Bayesian platform trial, which is a lot of words, but essentially what that means is that we've designed it such that we can make these comparisons between MMR and control. Because it's Bayesian, we can do regular interim reviews and, if necessary, can recommend stopping arms if we don't see signs of benefit. But we also have the potential in a platform to add additional interventions. And so that's the ultimate intention of Crown, is that we start with MMR, but as data emerges about the potential for other interventions, either drugs or vaccines to work, we could add them into the platform. And the third sort of novel feature about this trial design is that it's factorial. So in addition to comparing, say, MMR to placebo, if we add in other interventions, we could compare those interventions singly to placebo, or we could compare them in combination to placebo. But with a platform trial, what's great is that you're adding in arms. So you actually you only have one control arm, and you make all your comparisons with that control arm. So over time, in fact, it will be that the proportion of people who are allocated to a control may become smaller. So many people could potentially be in an arm that provides benefit. And if we see benefit during interim reviews, we can potentially then drop the placebo arm and make our beneficial intervention the backbone comparison and compare all new interventions to that. So that is the idea, is that we're aware that some people may not want to be allocated to a control. There are good arguments in this instance for starting with the control, but over time, the ratio of active to control may decrease. And in fact, if we show benefit, we may drop a placebo arm.
Thanks for that. That's really helpful. Sinead, could you speak to us a bit more about the drug? Where's it from? Who makes it? Do you have any thoughts on cost? What are the implications? Because obviously the role of pharma, specifically big pharma, has really characterized a lot of these weekly discussions. And of course, a spin-off around profiteering, access, price gouging, et cetera, So could you speak to us a bit more about this particular drug and where it comes from, who makes it, and then secondly, cost?
The measles, mumps, and rubella vaccine, there are two companies that make the vaccine that is registered in South Africa, GSK and Merck. We approached both companies and there was one that was able to provide the MMR to us. It was really important, in fact, that we not look for a central supplier, but that we get a supply that would be available in country. And the second consideration is that we didn't want to interfere with the national measles program. So we didn't want to take vaccines from the EPI program. And we knew the EPI program is considering moving to an MR vaccine, but they were in the middle of sort of getting that vaccine registered. So we approached, in the end, GSK are providing us with the MMR vaccine. They are not donating it free of charge, but they've given it to us at a reduced cost. And as a consortium globally, we've already started to have or initiate or flag the need to have discussions with, for example, at WHO about this approach to live attenuated vaccines, which are available much more cheaply to national EPI programs, particularly in bulk, so that they're aware of the potential demands, kind of the potential access issues, and that in addition to the work that's being done around specific vaccines, we're also managing potential issues around supply and scale up of manufacturing of these other vaccines.
Do we have an idea of what the current vaccine costs in the public health sector?
Well, because we don't use MMR in the public sector at the moment, I can't make a direct comparison, but I imagine that if once MR is licensed in South Africa, the costs are, my understanding is that the costs are, kind of US cents or small dollars, as opposed to kind of very large amounts, which might be associated with some of these newer vaccines, particularly that have complex technology.
Yeah. Thanks for that. Sinead, could you now speak to us a bit more about timeline? When is this trial going to be launched? What is your time frame looking like? And then as a follow-on, could you flesh out and describe a bit more of your community engagement and stakeholder engagement outreach plans for the trial?
So timelines, and as you know, Tian, there's a bit of a history to this trial. We've managed a pivot. So we're going through sort of the review of the new interventions with SAPRA and the ethics committees. We've received responses and have just sort of submitted our responses. So we're hoping that any day now we will get approvals. We're working with about 10 sort of institutional partners in South Africa who are experienced trial sites. A lot of them have come sort of traditionally from HIV prevention trials and TB trials. And so they have, each of those teams are very experienced with stakeholder engagement and have developed local stakeholder engagement plans. They have community advisory boards. Many of them include healthcare workers, and they've done local outreach. And in addition, there's work that we've done to sort of coordinate sort of at a national level. So doing outreach to groups like yourself, participating in a range of webinars, talking with the Department of Health, sort of as I mentioned earlier, working with sort of through our networks of professional societies, I suppose, so like the Infectious Disease Society of South Africa or the HIV Clinician Society, to really sensitize people to the trial, to the issues, and to have conversations like this where you flag up, for example, the important concerns about PPE. And that was really sort of informative in the early days. And because we live in a virtual world, I think there have been a number of sort of webinars. There's also, we have a website if people are interested called it's crowncoronation.com. We have some videos that explain how the trial is operated. We also have some investigators in Q&A explaining parts of the trial. So those, I think, have been sort of through broad brushstrokes, the sort of levels that we've worked at. So local around sites at a national level, but also across the global consortium. And I know that there are colleagues who are involved in the trial who are on the call who may actually be more eloquent than me about sort of the detail of the strategy. So if anyone wants to find out more, we can certainly call on them.
Great, thanks for that. Sinead, so mental health has been a huge issue around trials, and I'm particularly interested in finding out a bit more from you. What interventions have you put in place as a co-principal investigator for all of these trial teams, the site teams, your own team? What support is accessible for your team on this trial for their own mental health and their well-being? Have there been any specific interventions or additional capacity provided for them to access that?
So that's a really good question. I can say that this has not necessarily been sort of at the forefront of our planning, but I would say that I can reflect on my own team's experience. I think we've all had very practical experiences of dealing with COVID, both in terms of the impacts on staff as well as planning for how to run clinics and see participants who might have COVID. And clearly we've felt, I think, the surge that people experienced in July, where many people were ill, where there were a lot of decisions about how to manage work, how to kind of make sure that people are safe, what to do about sort of return to work and post-COVID symptoms. And it was a very practical experience of, yes, that was what that means in terms of the day-to-day stresses and mental health implications. So, I mean, in our team, we do have a program of debriefing. We do have access as part of our COVID SOPs. We actually have references to resources for mental health. We've worked quite closely with Lifeline as a group that is very interested in providing support to healthcare workers. And we have identified a number of other providers that are providing access to mental health services for frontline healthcare workers, so that they are able to at least have someone to at the best provide, or at the sort of simplest, sort of provide therapeutic listening and really kind of provide a space, I think, to articulate some of the concerns and stresses. Just yesterday, by the way, we were on a very interesting call with the Joburg District Research Committee, which is encouraging researchers to present their work. And there was some very interesting information just on people's experiences of mental health during COVID. And there clearly, it was not specific to healthcare workers, but there was some evidence to suggest that people who had high anxiety about getting COVID were more likely to experience depression. And often those people may have had a history of sort of childhood trauma. So that already gives us some insights into how we might want to encourage facilities, but also investigators at a local level to sort of talk to people about access to mental health resources. So it's a really important issue, and certainly one that I think we've all experienced. And I imagine that at a local level, investigators will be thinking about how to manage or support their staff, but also what that might mean in terms of what, kind of what facilities might need to do.
Thanks for that. Sinead, so apart from Crown, we know there's this tsunami of research happening, as has been happening, for at least the last few months. So within this whole melting pot of vaccine treatment research, what excites you the most? Which particular trial excites you the most and gives you the most hope and makes you think, well, what trial are you keeping your eye on in this whole landscape? Yes, on the spot.
I've got to be a proud mom and say, kind of, I think that this is I think we've put together an amazing group of investigators, and I think this is a very exciting concept. But I also, as a scientist, would say that the most important thing is to explore a range of options and to do trials that are going to provide results that are robust, that are able to sort of quantify risks and benefits. Because in my long history of working in HIV prevention, a flat result is as important as a positive result, kind of, and I think we've learned through the chloroquine debacle that, it's been important to have data in the face of lots of politics and spin and opinion. And what people need, I think, is clarity, and the trials will provide that. So I am interested in all the outcomes because I think all of them are important. And again, Tian, I think we've learned from HIV prevention, there isn't probably going to be a magic bullet. There are going to be some early exciting results. There are going to be results that say maybe if we do things in combination, this will be good. And all of it is going to be important because, kind of this pandemic, I think, needs a range of responses. And hopefully that we will have lots of important results in the coming years.
Great. Thanks for that, Sinead. A very, very smart sidestep there, but I will come back to you on that in coming weeks. Sinead, as we reach the end of the call, could you just remind us who are the funders of this trial?
Yeah, the biggest funder at the moment is the COVID Therapeutics Accelerator. That is a consortium which includes the Gates Foundation, DFID, the Wellcome Trust, MasterCard, and a range of other philanthropic organizations. And then locally in South Africa, the South African MRC has also provided funding. And then I think in some of the other countries, they've also had access to funding either from their research funding agencies or other philanthropic, or in some instances, crowdfunding sources.
Great. Sinead, so I guess my last question to you really would be, what message do you have to those who are perhaps sitting on the fence in terms of vaccines as a concept, firstly, and then secondly, to the anti-vaxxer movement, specifically in two regards. Number one, of course, in the time of COVID and the urgency of the pandemic. And secondly, considering one of your funders, the Gates Foundation, who we'll have on a webinar in the coming weeks, in 2 weeks' time, all of the controversy, the rumor mill, the fake news, the misinformation going out. Have you experienced any backlash? Do you anticipate any backlash on this trial as a direct result of Gates providing you with the support that it does?
Tian, you ask such a great question, and it's right at the end. And, kind of the vaccine confusion is definitely not helping. If I were to try and provide clarity of thought, the first is that I think as someone working in infectious diseases, vaccines are an amazing innovation. Essentially, they have learned from how the immune system works in responding to infections. and have provided basically as a technology that can prevent people getting those diseases. And often we need vaccines to control infections, because I think we've all seen these non-pharmacological interventions are difficult to implement, and they've been painful, both at a social, economic level, and they don't necessarily protect people from severe disease. So ultimately, vaccines are needed to control infectious diseases, particularly those of pandemic potential, like Ebola, like SARS-CoV-2, like HIV. And vaccines are the holy grail. And in fact, they have prevented a huge amount of death and disease. I am old enough that I can say that I had measles, I had whooping cough. I wonder if my mother was a delinquent mother or an anti-vaxxer. But, many of us don't remember people who got seriously ill from those diseases. My grandfather had polio, and he had difficulty walking. In fact, he was unable to practice as a doctor after he got polio because it limited his mobility. But we've been so fortunate to live in the world of vaccines that we've forgotten about the severe disease that it causes until we see outbreaks like we did of measles. So I think for those people sitting on the fence, it's that these vaccines have really revolutionized human health, and they've changed things like childhood mortality significantly, particularly in low and middle income countries, and really are an important intervention in our toolbox against really severe infections. So I think we need to ask ourselves, why are people concerned? And what I've understood is that for many people who are anti-vaccine, it may be a philosophical issue. There may be reasons that they have, but for the majority of us, most of us are concerned about our health, are concerned when we hear about safety issues. And so I think it behoves us as scientists and advocates and researchers really to talk to people about what we do and don't know about safety, to talk to them about how we generate data around safety, and really I think to sort of try to address the concerns that the middle ground have in order that they can feel comfortable to adopt vaccines, to see that the benefits potentially rapidly outweigh the risks. And if those risks are there, they're really infinitesimal and can be managed. But it's a complex issue. So it will require a lot of work from all of us.
Yeah, for sure. I'm going to take advantage. We do have 10 more minutes left, so we have 2 questions. Certainly within our work around the BCG Revax trial, some of our greatest allies have been in the trade and labor unions. Are you working with the trade unions, given the dynamics of the frontline workers and their challenges? And that question is from Steve.
I think we would definitely like to engage with the trade unions. In part, I think this is why we started having this conversation with the apologies, Tian, is it the COVID Front? I can't remember the
COVID-19 Front, yes.
Yes.
Yeah.
So it was precisely so that we could, in fact, reach out to unions to have conversations about this trial and about this research, and would definitely be keen to talk offline about sort of who we need to engage with further. Certainly, we have been talking to healthcare workers through our networks, and kind of can extend that further, but recognize the important role that groups like trade unions play in sort of potentially advancing healthcare worker literacy and sort of active participation.
Yeah, absolutely. And I think certainly immediately after this call, I will share your details on the group where we have representation of most of the trade unions, and extend your welcome for them to reach out directly to you, especially since it looks like we're still a few days, if not weeks away from the beginning of the trial. I think this is our last question. So Kathy asks, how was your interaction with SAPRA and the RECs? Were their concerns reasonable? And were you able to easily respond to them? And perhaps could you share some of those concerns if you can?
Yeah, so I think that generally we've had a very good working relationship with SAPRA and the ethics committees. I think it may help that we've been working in HIV for a long time and have understood that it's important to build good relationships and to create the ability to have conversations. In both times where we've gone to SAPRA with the protocol, we have asked for the opportunity to have a phone call, and certainly in the first iteration of this trial, we had a number of calls with the Clinical Trials Committee, and were able to have a good conversation about what their concerns were and to come up with a set of responses. Similarly, with the ethics committees, we've been able to have phone calls with a number of the chairs. We also worked initially through a process with the chairs to try and get a combined review across ethics committees. It's not to say that we all have the same opinion, but I do think that during this time of crisis where everyone has been working so hard, it's been incredibly important to try to talk to each other, to hear each other's concerns, and to try to be responsive. In terms of what their concerns were on this trial, there have been a relatively few, and in fact it's been more about explaining the concept of a platform trial and how it would work, and actually working through the processes for how we include new interventions, because I don't think this is something that we've used a lot in infectious diseases, and so that's sort of been an area of development for all of us. But I think that's quite exciting if we can lay the foundation for how we do platform trials for infectious diseases going forward in South Africa.
Great, thanks for that. I think the more and more you talk, the more you inspiring questions. So one question in the group. Speak to us a bit more about the political support for this trial. Do you enjoy widespread, unconditional political support for this trial, or is there more you would like to see?
Well, Tando has saved the most interesting question for last, it seems. I don't think that, so it's an interesting question, and I will say it is a conversation that I have had. I mean, and I'm curious to hear other people's views. It's been my observation that there has been tremendous support around one of the SARS-CoV-2 specific vaccines, and it generated a lot of positive citizen response, and that people from all walks of life have signed up to join this trial, which is essentially a safety and early efficacy. It's not yet the phase 3 trial. And it struck me that it was important that, you know, it is important when significant figures in society endorse these trials, because it inspires other people to join. And so I do think political support in the broad sense is really important, that having representatives from across civil society that say these trials are important, we're joining them. You know, we believe in the science. We believe that vaccine research is important for South Africa. It's important for us as a middle-income country who's going to have to procure these vaccines. And we need to also be at the table when they negotiate access, and this is one way to do it. So I would be curious to hear from you how we do generate that broad political support. We, I think, as a trial that's not promoting a specific SARS-CoV-2 vaccine, have tried to make arguments about why MMR might be for some people. But between you and me and the people on the call, I recognize that it may not be as sexy as a, you know, kind of a new vaccine. So how do we make it appealing, and how do we, you know, how do we generate the enthusiasm and excitement for this intervention, which may have benefit in comparison to some of the interventions? And how do we articulate that these ideas are all important, and we, you know, we have you know, stakeholders or leaders that are able to support the full range of trials that are being done for us as a country. So I think it's a great question, Ntando, and I'm curious to hear your thoughts on some of these ideas.
And we'll certainly be keeping that on the agenda, because I know as time goes on, we'll be speaking to some of the political players as well in the landscape. But in terms of the sexiness, I think you touched on an interesting point. I know certainly yesterday in some of the discussions we were having, I do think with MMR, there's a feel-good component. And so, I mean, personally, I know when I was young and I had mumps, and I just remember the most, I think it was the most annoying condition I've ever had in my life, because, you know, it's just here and it's just annoying. And of course, the relief that comes when mumps goes. And so I think there's certainly a strategic space, at least in terms of how you communicate around this trial, tapping into the positive vaccination memories people have from recovering from mumps or measles, which I think are some of the most, just generally, apart from infectious, just annoying childhood diseases. You know, if you aren't, you know, it's not something on your face, it's just a general feeling that that could perhaps be a strategy. I think we have come to the end of our chat. It's 4 minutes to the hour, so we're a bit ahead of time. Any last minute comments for people on the call and for civil society in general, in terms of how they can continue to support your work and engage with you? We'll certainly keep this platform open, but any last closing messages to civil society on their general role and how they could support the work that you do?
Well, just to say thank you to everyone for their questions, for the comments, and for the opportunity to engage. We welcome the partnership. We're going to follow up with you offline, Tian, about a number of sort of discussion points. We'd love to come back and give you updates as things progress. And certainly sort of a lot of what you've said has provided, I think, the investigators on the call food for thought. So thanks very much. And we look forward to being able to share good news with you. But even if we don't have a result, I think it will just be important to answer the question definitively, and to do it together, because this is a pandemic that needs a range of responses. So thanks very much.
Absolutely. And like we always say, there's never a wasted trial. Each trial tells us and gives us important and essential information. So thank you again. A reminder to colleagues on the calls, our new project website will be up and running in a few weeks' time, and on that website you can find all of the Zoom recordings, all of the chat transcripts, and full post-call reports, which will include transcripts of the question and answer sessions that we do during these calls. Next week, colleagues, we speak to Professor Qureshi Abdul Karim, who's doing some really exciting work and is part of the Ministerial Advisory Committee. So please join us for that. Sinead, thank you again so much for your time. We look forward to engaging. Colleagues who have joined the call, including the MMR team, thank you for your time in joining us, and we look forward to speaking to you next week. Thank you, everybody. Have a great Thursday.
Thanks, Tian.